So, welcome everyone to the FSR and Cleveland Clinic Awareness Month webinar, the Sandra Hodge Memorial Lecture. We're very excited for this program that we have for you today with Dr. Harper and Dr. Sharma. We're going to start off just by sharing a little bit of update from FSR, and then we will jump right into today's lecture. Just a note for everyone, if you want to ask questions, please use the Q&A button at the bottom of your screen to ask any questions, or you can utilize the chat. And we will be taking questions at the end of the webinar. In addition, there will be no opportunity to raise your hand or to be unmuted throughout the webinar, just as a note. And so we'll get started here. So just a little bit about the Foundation for Sarcoidosis Research for those that don't know. FSR was founded in 2000, and this is our 25th anniversary. So thank you to everyone who has been a part of this community and helping us to do all that we do every day. We are the leading international nonprofit organization dedicated to sarcoidosis, to patients and the services they need, and research. It is our mission to find a cure for sarcoidosis and to improve the care for everyone who is impacted by sarcoidosis. And we are driven by a cooperative and communicative relationship between patients and researchers. We are 70,000 strong as our community with 50 states and over 80 countries that are part of the community. It includes patients, caregivers, family and friends, clinicians, healthcare providers, clinics, researchers, donors, fundraisers, volunteers, staffs, committees, and lots of other people engaging with us every single day. It is, of course, Sarcoidosis Awareness Month, so we encourage all of you to continue to help us raise awareness by social media, by sharing your story with family and friends and loved ones, and helping to get the word out. Just very quickly about what the Foundation for Sarcoidosis Research does. We help to accelerate research through funding opportunities, through engaging directly with our scientific advisory board and our partners. We also have clinical engagement that we do to help educate and provide networking and resources for those that are practicing clinically to support those living with sarcoidosis. We support patients through patient advocacy. We have a patient navigator program that provides one-on-one support, a national patient support group, as well as local patient support groups through our FSR Global Sarcoidosis Clinic Alliance and wellness programming. We educate through webinars, town halls, podcasts, infographics, and summits like the one that I'll talk about in just a moment. And we advocate on Capitol Hill, working directly with the FDA, the NIH, and our pharmaceutical partners to reduce barriers to good care for every patient living with sarcoidosis. Just a few things that are coming up here in the next few days. We want to make sure that you know about a webinar that we are having tomorrow on accelerating sarcoidosis research together. You'll hear from Dr. Alicia Gerke, who was an awardee of a grant from FSR, and her colleague Emma Thorell, who will also share a little bit about all the work that they have done in raising awareness about sarcoidosis and doing really critically important research, especially on the environmental impact of the causes for sarcoidosis. So this is one you don't want to miss. So the registration is in the chat, so feel free to register for this. We'll also be following up on April 22nd with a webinar on physical therapy. We did a webinar earlier this year on physical therapy, and we had just tons of questions that came in on how to think about exercise and sarcoidosis. So this will be just a live Q&A session with our two speakers, Marianne Potesnik and Claire Child, who will be sharing insights for us and helping to answer any questions. So come armed with any questions that you have and would like to have answered, so we can spend the time answering those questions together. As I mentioned, it is Sarcoidosis Awareness Month, and our theme this year is Facing Sarcoidosis Together. There are lots of ways you can get involved by attending an event, lighting something up purple, posting a photo of you and your family, your friends, and pets in purple. You can visit our Awareness Month page, which is in the chat, attend some of our educational webinars, or listen to the Sarc Fighter podcast, and of course, follow us on social media and help us get the word out as well. And before I turn it over to our fantastic speakers for this evening, just wanted to let you know that we are again hosting our FSR Virtual Patient Summit, which will be taking place this year on June 28th through 29th. This is an interactive 2-day session with lots of networking opportunities to meet other people. It has world-renowned experts, opportunities to interact with other patients and the clinicians, and topics of lectures back to back, really chocked full of topics around disease manifestation, research, symptom management, treatment management, and so much more. So please do click the link that you see in the chat to learn more about the summit, and we hope to see you there. And with that, I will introduce our speakers for today. So Dr. Logan Harper is a staff physician at the Cleveland Clinic Sarcoidosis and Interstitial Lung Disease Center and assistant professor at the Cleveland Clinic Lerner College of Medicine. His clinical focus is on complex sarcoidosis patients with a focus on underserved populations. He is a member of the Cleveland Clinic Community Lung Clinic, which focuses on providing comprehensive and expert care to underserved groups surrounding the Cleveland Clinic area. His current research focuses on developing interventions collaboratively with sarcoidosis patients to reduce healthcare disparities. And Dr. Sumit Sharma is a retina and uveitis specialist at the Cleveland Clinic Cole Eye Center, where he is the uveitis fellowship director and medical director for information technology. Dr. Sharma is also an assistant professor of ophthalmology at the Cleveland Clinic Lerner College of Medicine. Welcome to you both.
Thank you, Trisha. So I am gonna get sharing. There we go. That should be doing it. Hello, everyone. As Trisha said, I am Logan. I'm one of the sarcoidosis doctors, and I'm thrilled to be able to be giving this talk today. Talking about the treatment strategies for sarcoidosis and how we can move beyond steroids. I wanted to pause and talk about how this year we're dedicating our Sarcoidosis Awareness Month lecture to Sandra Hodge. Sandra was a founding member of the Cleveland Clinic Sarcoidosis Community Advisory Board. She served on the board for 3 years and was a passionate advocate for patient agency in all areas of sarcoidosis care. She she sadly passed away from sarcoidosis this year. Um, the members of the Cleveland Clinic Sarcoidosis Community Advisory Board and the Cleveland Clinic Sarcoidosis Clinic wanted this year's Sarcoidosis Awareness Month lecture to honor all the ways in which Sandra Hodge impacted our lives. Whether that was making us laugh at the beginning of meetings or keeping us organized as we planned events or pushing us to set higher goals for how we were going to impact other sarcoidosis patients. For today's talk, I want to cover 3 things. The first thing I want to cover is, when do we treat sarcoidosis? Because as we'll see, that is one of the key questions in sarcoidosis care. Next, I want to talk about why we use steroids and look at some of the data that drove us to use steroids in sarcoidosis. And then after that, I want to talk through some of the other drugs that are options for sarcoidosis and give an example of how we use them in clinical practice. So, when to treat in sarcoidosis? Recently, an article was published codifying Wells' law, which says that you treat sarcoidosis when there's either danger or there is impaired quality of life. And what this is saying is not everyone needs to be treated. Only those who have progressive organ damage or are having symptoms from sarcoidosis. What are some examples of people who wouldn't need to be treated with sarcoidosis? The most common symptom that doesn't need to be treated is called hilar lymphadenopathy. And these are patients who simply have enlargement of the lymph nodes in their chest. I'm not sure if you're able to see my mouse here, but these are lymph nodes on the CT with the red arrows pointing to them, and these are lymph nodes on the chest X-ray with the red arrows pointing to them. Patients who have only lymph nodes in the chest and no symptoms usually will never need to be treated. Another form of sarcoidosis that often doesn't need to be treated is sarcoidosis of the bone. Frequently, we will see these areas on the skeleton. On this scan here, we are looking at a patient's pelvis, and that bright yellow circle is an area of inflammation in the bone. And if there's no pain, we can just monitor this. Interestingly, we haven't seen patients having progressive destruction of their bones from sarcoidosis. The key point here is 50% of patients with sarcoidosis will never need to be treated. And a frequent question I find myself asking in clinic when a sarcoidosis patient is having new symptoms is, are these symptoms from sarcoidosis or are they from something else? So many patients, when they are treated, are started off on steroids, and many patients who are on these have experienced a lot of toxic side effects. This quote is from a paper in the New England Journal of Medicine, the top the top the top medical journal from 1951. And this was the first description I could find of steroids as treatment for sarcoidosis. And you can see many other things had been tried that were also very toxic. They tried Fowler's solution, which is a compound of arsenic. They tried radiation and a form of mustard gas. In 1967, this was one of the earliest trials I could find of sarcoidosis, and they gave 27 sarcoidosis patients prednisone, 24 of them oxyphenobutazone, which we don't have to worry about because that's been taken off of the market, and a placebo. And you can see that you can see that many patients improved on the prednisone, and this was much more than the placebo, showing us what we know now, that prednisone does work for sarcoidosis. As a side, oxyphenobutazone is the theoretical highest scoring word possible in Scrabble. Although you're gonna have to get very lucky and have your opponent in Scrabble play several of the other letters for you. It's never actually been played in competitive Scrabble. Moving back to science, a recent study, the most recent controlled trial I found of prednisone in sarcoidosis validated everything we saw in that early trial from the 60s. In patients who have stage 1 sarcoidosis, and those are patients with the lymphadenopathy that we talked about don't need treatment earlier, prednisone doesn't do anything. We do see an improvement, though, in patients who have scarring in their lungs, either nodules or a little bit of scarring when they're treated with prednisone, confirming what we've seen in past data. Unfortunately, the story doesn't end there because steroids have a lot of side effects. This graph here on the right is comparing patients who are not on a steroid with the line on the bottom to patients who are taking a steroid to the line on the top. And the line goes up every time a patient develops a side effect from steroid. And what you're seeing here is over a 5-year period, about 60% of patients treated with a steroid developed a steroid side effect, compared to only 30% of people who weren't treated with steroids, highlighting that these drugs can be very toxic. So our key points here is that steroids are helpful, but we really have to be careful that the side effects don't outweigh the benefits we see. So what is our option in someone who needs to be treated, but we don't want to give them high doses of steroids? In that case, we use drugs that we call steroid-sparing drugs. And these are drugs that calm down the immune system and make it so we're able to treat sarcoidosis with less and sometimes no steroids. The first drug that was tested was methotrexate. And this is a drug that is frequently used in rheumatoid arthritis. This drug was tested as a second-line agent in this study. And second line means only used after someone had either failed prednisone or developed side effects. In this small study of 15 patients, what we see here is the prednisone dose, the line on the bottom, lowers more over 6 to 12 months in patients who are treated with methotrexate, the line on the bottom, compared to patients who were treated with placebo, the line on the top. In 2025, we're taking another look at methotrexate. And this study was recently completed using methotrexate as a first-line drug. And that means a patient comes in, they have sarcoidosis, we don't give them any steroids, we go right to methotrexate. The results of this trial haven't been fully published yet, but they have been presented at a couple conferences. And what they showed is methotrexate by itself works just as well as prednisone, but it does take 3 to 6 months to fully kick in. We are waiting for the final papers to see if this translates to less side effects for patients. Methotrexate isn't the only drug in our arsenal. A second steroid-sparing drug that we use frequently is called azathioprine. Azathioprine is also a drug frequently used in rheumatoid arthritis. It's also used a lot in Crohn's disease. And like methotrexate, it works by calming down the immune system. It actually has pretty similar side effects to methotrexate as well. The only difference is azathioprine has a little bit higher of a rate of people developing an infection when they're on it. This graph on the right is a graph showing that for patients either with or without pulmonary sarcoidosis, methotrexate and azathioprine were just as effective on keeping lung function tests stable. So if the drugs are very similar, how do you choose between them? And a lot of our decisions come down to the side effects we see with the two drugs. And like prednisone and really all drugs, methotrexate and azathioprine do have side effects. GI side effects are the most common, with nausea and diarrhea, although those are often mild and can be managed. Both of the drugs can also cause liver issues and low blood counts. And because of that, we have to do monitoring of blood tests every 1 to 2 months. And if any of these problems develop, they usually completely go away if we stop the drug. The main side effect of both of these drugs is an increased risk of infection, which we see with these drugs and also with steroids. So patients taking immunosuppressant drugs really have to let their doctors know if they're having symptoms that suggest they are having an infection. Often, when deciding between these drugs, what I focus in on is, has the patient had a side effect on one of the drugs? If they have, I will try the other, because just because you have nausea on methotrexate doesn't mean you're going to have nausea on azathioprine. The same thing goes for the low blood counts. Sometimes when patients are drinking alcohol, I will have to use azathioprine because methotrexate really shouldn't be used with alcohol use. And for patients who are thinking about getting pregnant or who are pregnant, azathioprine is our drug of choice because methotrexate will cause birth defects in a pregnancy. So outside of those drugs, azathioprine and methotrexate, which are pills and are general immunosuppressants, our favorite class of drugs right now as sarcoidosis doctors are the TNF inhibitors. And these are drugs that target a specific protein that is involved in the granulomatous inflammation process of sarcoidosis. There's two main drugs we use: infliximab, which is a once every 4-week infusion, and adalimumab, which is a shot a patient can give themselves at home every 1 to 2 weeks. A recent meta-analysis, which is a type of study where you grab multiple trials and you pool them all together and you try to estimate the total effectiveness of a drug based on all the data out there, found that infliximab improved sarcoidosis symptoms of the skin 89% of the time, of the nervous system 77% of the time, and of the eye 69% of the time. And they also showed that TNF inhibitors frequently allowed for a reduction in steroid dose, which is really one of the main things we're trying to do with all of these drugs. This picture on the right is an example of an individual who had sarcoidosis of the skin and had a really great improvement after being treated with infliximab. So how do we put this all together? This flow sheet is taken from is taken from the recent guidelines of treating pulmonary sarcoidosis. And I want to walk through how we as physicians and sarcoidosis clinicians would use this guideline in treating a patient. So I'm going to start off with a case. And this is a 45-year-old male who comes to the sarcoidosis center after he had a chest x-ray taken when he was being treated for pneumonia, and it identified this hilar lymphadenopathy on both sides of the chest. We're going to assume this gentleman has been confidently diagnosed with sarcoidosis with a biopsy, and we have ruled out any signs of sarcoidosis in any other organ. A patient like this would count as low risk pulmonary sarcoidosis, and our options are to observe them and to try a low-dose prednisone regimen only if they're having symptoms. So for someone like this, I would typically recommend that we touch base every year, make sure they're doing well, but I wouldn't anticipate they would ever need any treatment. This second case is more typical of what we see in sarcoidosis clinic. And this is a 55-year-old man who comes to the clinic after he was found to have sarcoidosis after developing shortness of breath and a cough. And on this chest x-ray, you can see the swelling of the lymph nodes in the center of his chest. And you can also see these kind of hazy streak marks in the periphery of the lungs. And that is inflammation in the lung that is causing his shortness of breath. There is still a little debate as to what we should do as our first step. But typically, in a case like this, most centers would try a course of steroids and see, are we able to treat the sarcoidosis symptoms and wean the steroids down to a dose where we're not causing a lot of side effects. In this case, we're saying we tried a dose of prednisone, and at a moderate dose of prednisone, the shortness of breath was greatly improved. But as we lowered the dose, the shortness of breath comes back, and the patient starts developing steroid side effects of weight gain, bruising, difficulty sleeping, weird anger and depression, and acid reflux. In this setting, clearly the steroids are both hurting and they're not helping enough. So we have to think of something else. In that setting, we move a step down the algorithm, and the recommendation is to try one of the oral immunosuppressant drugs. So for this patient, we're going to add methotrexate at a low dose and then gradually titrate it up to a moderate dose. While we're doing this, we're able to lower the patient's steroid dose down to 0. Their symptoms are better, and their chest x-ray is mildly improved and is staying stable. So we are very happy with how treatment's going. After 6 months of treatment, though, we start noticing that the patient's ALT and AST, which are proteins that are made in the liver, are creeping up. In this setting, we're concerned that the methotrexate is starting to injure the liver, so we stop methotrexate therapy. With stopping therapy, the AST and the ALT come down and the liver's doing great. but now the shortness of breath comes back. So what we've learned here is this patient can tolerate a low dose, but not a moderate dose of methotrexate, and we need to find a different drug. In this setting, we will often switch to a different one of the oral drugs. In this case, we're going to switch over to azathioprine. And the patient's shortness of breath improves, but they start having nausea and some vomiting on the azathioprine. And it doesn't improve with any of our normal ways of dealing this, be that taking it with food, taking it before bedtime, or sucking on hard candies when they're having nausea. In this setting, we have failed 2 of the oral drugs, and it's time to move another step up the ladder. And in this case, I would start thinking about one of our TNF inhibitors. So now we're saying our patient has persistent sarcoidosis activity and they're not tolerating drugs. So we start them on infliximab every 4 weeks. With the infliximab, we also start them back on a low dose of methotrexate, which they tolerated. And the methotrexate in this case isn't meant to treat the sarcoidosis. It is meant to prevent the body from creating antibodies that make it so the TNF antibodies we're giving aren't able to bind to the TNF protein. If you develop these neutralizing antibodies, your body becomes immune to infliximab and it stops working. With this treatment of infliximab and low dose methotrexate, the patient's breathing improves and they're not having any significant side effects. So the takeaways from this are there are many effective medications for sarcoidosis that are not steroids. I also really wanted to highlight how all of these drugs have side effects and everybody has different side effects. And this means that there isn't one perfect regimen that'll work for all sarcoidosis patients. And generally at the beginning, there is a little bit of working our way through the algorithm and finding the drugs that are best for each individual patient. And this really highlights how important it is for all sarcoidosis patients to really pay attention to their bodies and see what's happening when a new drug is started and let their doctor know. This has been a little bit of an idealized case. There are some patients who there really isn't any regimen where they're completely side effect free. So it's always a conversation between the patient and their care team of what are the side effects you're having? Are they tolerable? Are they not tolerable? How active is the sarcoidosis? And is now the time where we should really pull the trigger and try something else? I'll take questions after we hear from Dr. Sharma, but I wanted to put in a quick plug for our sarcoidosis meetup we're having at Cleveland Clinic. We're having a bowling social at Spins Bowl in Independence, Ohio. We've rented out four lanes. There's going to be sarcoidosis nurses, physicians, our community advisory board, and we would love to see you, your family, and really just build a sense of community for sarcoidosis patients, their caregivers, and their friends. And with that, I am going to hand this over to Dr. Sharma. Thank you, everyone.
Oh, all right. Thank you. Let me pull my slides up. Give me 1 second. Great. Are those showing? Yes. Okay, great. So I'm going to give an overview of ocular sarcoidosis and kind of the range of things that and manifestations we can see with sarcoidosis in the eye. When we talk about ocular sarcoidosis, what we're really referring to is uveitis in most cases. And uveitis refers to inflammatory diseases of the eye and the ocular surface, and it's not just one disease. There's about 300,000 patients in the United States who suffer from uveitis, and 20,000 of them are children, and many of those cases are often related to sarcoidosis. And unlike other parts of the body, inflammation in the eye is directly visible on examination. We can see the inflammatory white blood cells floating either in the front or the back of the eye. And we can quantify that severity based on both our examination and imaging that we do in the eye. And I'm going to talk about some of those things. So when we talk about ocular sarcoidosis, we're really referring to is sarcoid uveitis in the vast majority of cases. And sarcoidosis in the eye can present either acutely with very severe symptoms, or it can be chronic and completely asymptomatic. So often it's misdiagnosed, or worse, things are missed until the ocular findings are severe and there's been extensive damage to the eye and loss of vision. It can affect all ages, but there's a peak onset in your 20s and 30s, and then a second peak of sarcoid uveitis in the 50s and 60s. And a large percentage, between 30 and 60%, depending on which series you look at, of patients with sarcoidosis develop some type of involvement of their eyes at some point in their lives. And about 5% of patients with uveitis have it because of sarcoidosis. So it's by far one of the most common causes of uveitis is sarcoidosis. And finally, 30% of patients who develop sarcoidosis have uveitis as their initial manifestation. So 1 out of 3 patients with sarcoid will have uveitis as the diagnostic manifestation before they're actually diagnosed with sarcoidosis anywhere else. And as Dr. Harper very nicely outlined, the best way to diagnose ocular sarcoidosis is biopsy. But biopsying in the eye is associated with a lot of morbidity and vision loss. And because of that, we often rely on other tests such as chest x-ray, a chest CT, and a biopsy of sites other than the eye that's often safer. So even though we'll have a patient with eye-only disease, no signs of anything elsewhere, we'll often pursue a bronchoscopy in order to get the diagnosis if the suspicion for of sarcoidosis is very high. Well, what can sarcoidosis do in the eye? It can do a whole lot. It can pretty much manifest as any type of inflammation in the eye. You can get scleritis, you can have an inflamed lacrimal gland, you can get dry eye, you can get granulomas, you can get a droopy eyelid, you can get inflammation of the eye muscles, and it can lead to glaucoma. And the types of uveitis, pretty much any type of uveitis that we know of, and so this is a huge long list, and I'm not going to name them all, but any type of them can show up with sarcoidosis. And so what our recommendation is that any patient with a known diagnosis of sarcoidosis should see an ophthalmologist once a year for a dilated exam to look and see if there's any signs of uveitis in the eye. And if it's possible, at least when you're initially diagnosed, we recommend seeing a uveitis specialist for the first couple of years. If you get past the first couple of years without any signs of eye involvement and the sarcoidosis is under well controlled, then following up with a general ophthalmologist is okay. But anyone who's symptomatic should have an eye exam as soon as possible to see if there's anything that's going on that's related to the sarcoidosis. So what are the symptoms you can get? Well, it really depends on what part of the eye is affected. And when we talk about uveitis, we kind of split it up by anatomic location and type of inflammation that you're seeing. So the front of the eye, when it's the only site of involvement, we call that anterior uveitis or iridocyclitis or iritis. All of those things mean that the inflammation is limited to the front part of the eye. And it can present in one of two ways when it's limited to the anterior part of the eye. It can either be acute, meaning it comes on very quickly, with a combination of pain, redness, and light sensitivity with a definitive start date. And it can be self-limited, where the symptoms actually go away after a little bit of time. But usually it requires treatment when you develop these symptoms of pain, redness, and light sensitivity. But there's another variant of sarcoidosis that shows up that's very chronic. It comes on slowly. It's often asymptomatic, meaning you don't notice that you have it. Sometimes patients will complain of floaters or decreased vision, but the history is less precise and it happens over a long period of time, sometimes many years before these patients are diagnosed. So that's why it's important to get an exam, even if you have no symptoms with the eye. Moving back in the eye, so we started with the front of the eye, that's anterior uveitis. Intermediate uveitis is affecting the vitreous jelly, the middle part of the eye that fills the entire eye. And typically the symptoms here are either floaters or spots in your vision or blurred vision. And when we look in the eye, we can actually see groups or clumps of white blood cells that we call snowballs if they're floating in the vitreous, or snowbanks if they're sitting on the retina, because they look like big clumps of white blood cells actually either floating in the eye or sitting on the retina. And when we see that, we often think of sarcoidosis as a possible cause. And then you can have posterior uveitis, where the inflammation is in the retina. So the retina is the light sensing part of the eye that captures light and turns it into a signal our brain can understand. Or the choroid, which is the high blood flow vascular supply to the outer part of the retina. And we can see this as either inflammation of the retinal blood vessels, which we call a periphlebitis. And you'll see if you look online, you may see something called candle wax drippings. And these are because there's leakiness from the blood vessels. And that leakiness often looks yellow, and it follows a pattern along the blood vessels, looking like candle wax is dripping off of the blood vessels. Or you can have granulomas in the choroid, just like you can have granulomas anywhere else in the body with sarcoidosis. And with posterior uveitis, there's a much higher risk of permanent vision loss if it's not caught and treated very quickly. Usually with posterior uveitis, patients are very symptomatic with blurred vision as their main complaint. And then finally, you can have panuveitis, where all parts of the eye, the anterior, intermediate, and posterior segment of the eye are involved. And the symptoms can combine all of the ones that I mentioned before, where you can have redness, pain, floaters, and blurred vision. And this often is the most severe form of uveitis from sarcoidosis, and it requires very aggressive treatment. You can have inflammation of the lacrimal gland, which is the tear-producing gland of the eye, and that can cause swelling of the upper eyelids and lead to dry eye. And it's often treated with either steroids or tear-stimulating medications, or with treating the underlying sarcoidosis using the algorithm that Dr. Harper told us earlier. And then there's other types of inflammation. You can get scleritis, where you have a very red and painful eye, granulomas of the conjunctiva, or the skin covering either the eye or underneath the eyelid. Usually these are not symptomatic, but sometimes you can see or feel little bumps under the eyelid or have some tenderness. You can have inflammation of the eye muscles, which is known as orbital myositis, and this will cause pain with eye movement. And then finally, you can have inflammation of the optic nerve. This is the nerve that carries sight from the eye to the brain, and this can lead to dimmed vision and loss of parts of your visual field. Often it is very symptomatic. When we talk about coming in for an eye exam, we're going to do a combination of a few different things. You're going to get a slit lamp exam, where we look at the front of the eye, examine the lacrimal gland, and then we dilate your eyes and look at the back to look at the retina and the choroid. If there are specific findings, we may order some imaging. That imaging of the eye can include testing like optical coherence tomography, which is a high resolution cross-sectional image of the retina or other parts of the eye to try to see what's going on. Or we'll do a dye-based test, where we inject a dye in one of the veins in your arm and then take photos of the eye to see what that dye does. Normal blood vessels don't leak any of that dye, but when there's active inflammation from something like sarcoidosis, we can see the dye leaking out of the blood vessels in different patterns. And the patterns that we see can help us determine A, the diagnosis, and B, how active it is and how it responds to treatment. So this is a patient with sarcoidosis that's very severe, and this is one of those dye tests showing all that white area is leakiness of the blood vessels, and then they get treated, and we see almost all of that go away, and we see very clearly and defined what the blood vessels look like and how they are no longer as leaky. They're not completely gone. There's still some subtle leakiness, but it's significantly improved. Another dye test that we can do is indocyanin green, and this exploits different sizes of the dye itself. And what this dye test can show us is what the choroid is doing and whether there's any granulomas in that blood vessel supply underneath the retina. And that can often be seen in cases with sarcoidosis. We'll also often do photos of the retina to try to see what's going on. And on the left here, you have a photo of the retina. The optic nerve is that yellowish area in the middle, and then the blood vessels coming off from it. And in this patient with sarcoidosis, the photos didn't show much of anything. They looked pretty normal. But when we get that indocyanin green angiography test, we can see all these dark areas or little granulomas in the choroid or that layer underneath the retina. And this is from sarcoidosis. And with treatment, those lesions in the choroid go away, and the dark spots or scotomas in this patient's vision improved significantly. And then finally, we'll sometimes get an ultrasound of the eye, and that's done in the office looking for different things around the eye or in the eye as a possible cause of inflammation. So what do some of these things look like? You can get a wide variety of appearances in the eye. This is what the normal front of the eye should look like. This light reflex here is the slit lamp beam shining on the cornea. You can see that light then shines on the iris or the colored part of the eye. And the pupil here is where there's no iris, and that allows us to see into the back of the eye. This is a pretty normal looking front of the eye. In sarcoidosis, we get lots of different appearances that we've talked about already. And so I'm going to show you what some of those things can look like. This is a CAT scan of the brain and orbits. And what we're looking at is this side looks completely normal. But on this side, this muscle is completely invaded with a granuloma, a very, very large granuloma from sarcoidosis, causing what we call orbital myositis. The other thing you'll notice is that mass is so big from the granuloma that it's actually pushing the eye forward, because this eye is much further forward compared to this eye. And so that bulging of the eye is one symptom in very severe orbital myositis. You can have the lacrimal gland involved, where the lacrimal gland is thickened and inflamed. We can see those granulomas that I was talking about underneath the conjunctiva. So this is on flipping the eyelid. We see a granuloma there. You can develop scleritis or inflammation of the white part of the eye, and that is causing these blood vessels all throughout this portion of the eye to be very inflamed. You can get nodules of the iris, these white little lesions. These are actual granulomas from sarcoidosis in the iris. And then you can see granulomatous inflammation, or those white blood cells clumping together and sitting on the back surface of the cornea. And this is another patient with a similar appearance. With very severe and extended periods of time of inflammation, the iris can actually stick to the lens, and we call that posterior synechia, and also lead to the formation of cataracts. And this requires surgery to fix. You can get the inflammation that I was mentioning in the back, those white blood cell clumps, the snowballs, because they look like snowballs floating inside the gel of the eye. And then you can have the blood vessels inflamed, as I was mentioning earlier. And then this is those candle wax drippings around the blood vessels. You can have a granuloma in the optic nerve itself. And in this patient, they also have retinal vasculitis or inflammation of the blood vessels. And it can get very, very severe, where you can see bleeding and lots of damage. And this is very symptomatic with severe vision loss that requires very aggressive therapy to get under control. You know, granulomas either in the retina or the choroid, and it can lead to retinal detachment and vision loss from a retinal detachment. You can develop swelling in the retina, known as cystoid macular edema, where that dye is leaking into the retina, and because those blood vessels are inflamed, and inflamed blood vessels leak. Just like if you sprain your ankle, it swells up. When the retina is inflamed, it leaks and swells and leads to blurry vision. So how do we diagnose ocular sarcoidosis? So it's based on clinical eye findings and clinical imaging in the eye, and then often requires other testing. So getting blood tests, getting chest imaging, and getting biopsy showing non-caseating granulomas. We have to rule out things like tuberculosis and syphilis because ocular sarcoidosis can, those two diseases, TB and syphilis, can often mimic ocular sarcoidosis. The lab testing that can be used is an angiotensin converting enzyme, a serum calcium, lysozyme, and then, like I mentioned, screening for tuberculosis and syphilis, but they're not 100%. They don't always lead to the correct diagnosis, and often they can be normal even when the diagnosis is sarcoidosis. That chest imaging often helps, but I've had patients where all the chest imaging, it ends up being normal, and I still think that it's ocular sarcoidosis, and will often do a bronchoscopy and a biopsy looking for the diagnosis. In terms of controlling the inflammation in the eye and how we treat ocular sarcoidosis, often it's with the same medications that Dr. Harper was mentioning earlier. Our goals are to control inflammation and so that we can prevent vision loss and minimize the medication side effects. But the approach really depends on how severe the eye disease is and what part of the eye is involved. The good thing to know and the important thing to note is that with treatment, we can control the inflammation in the long term. And when we control the inflammation, we can prevent or treat vision loss. But it requires a multidisciplinary approach. And so that means that often we will work together with the lung doctors to come up with a treatment plan and to treat you so that not just the eye is controlled, but your systemic sarcoidosis is controlled as well. So Dr. Harper went through a lot of this, and so I'm not going to repeat that. But we can often use local therapy at the eye with steroids, and this can take the form of eye drops that are given if there's mostly front of the eye disease, or it can involve injections given either into or around the eye of steroids. We have new therapies in clinical trials that are non-steroidal therapies to treat inflammation in the eye, and got some exciting things in development for the future with 2 or 3 different medications right now that look very promising as non-steroidal anti-inflammatory treatments given directly in the eye. So avoiding all of the steroid-related side effects potentially. And so one of those medications, we should find out if it's going to be successful or not later this year. The others are still a few years away. Finally, I'll finish up talking about some complications that can happen. You can get glaucoma, which is damage to the optic nerve often from high eye pressure, and that can result from either the inflammation itself or from steroid use. You can get cataracts, again, either from the inflammation itself or from the steroid use. You can get swelling of the retina, and you can have vision loss, often from the inflammation if it's not treated adequately, but other times from the complications of the inflammation or sometimes complications of the treatments. Often patients with sarcoidosis will need some types of eye surgery, and that can include cataract surgery, but we want to make sure the inflammation is under very good control before we do that. Other times it can require glaucoma surgery to control the eye pressure, a vitrectomy where you go in to remove the vitreous gel or rarely do a biopsy if the diagnosis is very unclear, or surgery in the orbit for a lacrimal gland biopsy. When we talk about how you deal with and live with ocular sarcoidosis, the important things are to adhere to the treatment plan, monitor your symptoms, and if you have a severe vision loss in one eye, wear protective eyewear. Make sure you attend all your scheduled eye exams, and if things aren't improving or going the way they should be, escalating care to see a uveitis specialist is often necessary. In terms of self-care, you also need to do that. You need to join patient groups. You need to learn about your condition, but really coordinate and communicate with your care team. Seek counseling if you're feeling overwhelmed, and maintaining a healthy lifestyle, including sleep, diet, and stress management, is important because I do feel and find that stress plays a big role, and poor diet and poor sleep often can precipitate attacks of ocular sarcoidosis where there's active disease. But the most important thing to remember is that most patients with ocular sarcoidosis maintain good vision with treatment. And while some need long-term medications to stay stable, early detection and care You can prevent a vision loss, and we really can control the inflammation in the vast majority of patients. It would be very rare where we can't. But the prognosis does vary based on the severity of the inflammation and the complications. And please get a regular annual eye exam with an ophthalmologist. And if you need to escalate care, make sure you get in with a uveitis specialist who's comfortable and familiar with all the different forms of ocular inflammation that are seen in sarcoidosis. But again, I really want to emphasize that with proper treatment and control of the inflammation, we can prevent vision loss for you. So my final takeaways are sarcoidosis can be very symptomatic, or it can silently affect the eyes. Uveitis is the most common ocular manifestation. And please, please, please remember that you're not alone and that support is available and that we can work together to treat this. We've got a big team at Cleveland Clinic in the ophthalmology department that specializes in ocular sarcoidosis. And please feel free to reach out at any time if there's any issues or concerns. Thank you.
Thank you to Dr. Harper and Dr. Sharma, and we have lots of questions for both of you. I am going to start off to give Dr. Sharma just a moment to catch his breath after that fantastic presentation. Dr. Harper, I'm going to start off with you and ask you just a few questions that we had. First and foremost, there was a question about how do you know with certainty the symptom that you are having in an organ is sarcoidosis and not something else? Do you have to have biopsy of every single nodule that would show up on a PET or an MRI?
Yes. So the diagnosis of sarcoidosis is really an ongoing process in every patient. Like I said earlier, sarcoidosis really can pop up in any organ. So every time I see a sarcoidosis patient in clinic, I'm really thinking, are there any new organs involved? And of the organs that I know are involved, is sarcoidosis controlled in every organ? One of the challenges is medicine is never really an exact science. To know exactly what is going on, we would have to do a lot of very invasive things that wouldn't help people actually be healthier. So a lot of times, if you really press us, we're only about 95 to 99% sure what's going on. And a lot of the work in sarcoidosis is following patients over time to see, are the symptoms we're seeing behaving like sarcoidosis, in which case we're safe to continue assuming that it is, or are the symptoms now not behaving like sarcoidosis and we do have to do additional testing? And that can be really stressful for everyone, the patients, their doctors, their families. And that's something we try to be sensitive to.
Thank you, Dr. Harper. And one more question before I go back over to Dr. Sharma with some questions. We get a lot of questions about TNF-alpha inhibitors. Do you mind just saying a little bit more about those drugs and when in the treatment course people should be considering those as a therapy?
Yeah. So TNF inhibitors are something that we often reach for when patients are having challenges on our oral drugs. And I will say a lot of our treatment algorithms in sarcoidosis and really all diseases are driven by what insurance will cover, because the TNF inhibitors are very expensive, and we have to show the insurance companies that we tried other things first. So typically in my practice, I start TNF inhibitors after a patient has failed, after oral drugs have failed the patient twice. I really liked the one patient who pointed that out earlier. Thank you for that. There are some cases where I try to jump to the TNF inhibitors quicker, and those are neurosarcoidosis and bad cardiac sarcoidosis. But honestly, that often depends more on the patient's insurance than what I want to do, unfortunately.
Thank you, Dr. Harper. And one other question, just quickly to piggyback on that. When people are starting TNF inhibitors, can they be on them without steroids?
Yes, you can certainly be on a TNF inhibitor without steroids. I have seen some patients on TNF inhibitors without any other drugs. In in my practice, I usually have a low dose of something like azathioprine or methotrexate just to be very sure that we don't develop those drug neutralizing antibodies.
Thank you very much. And so coming over to you, Dr. Sharma, um, we had a question around bleeding behind the eye and whether that is a symptom of sarcoidosis. I'm going to ask you a few symptoms that people have
Yeah.
highlighted, but I'll start with that one.
So the challenge often with sarcoidosis is that there can be a big overlap. So can you have bleeding in or in the retina or behind the eye? When most people talk about behind the eye, they're referring to bleeding in the retina. Yes, absolutely you can. But it can also, bleeding in the retina has a list of different things that can cause it. That's about a couple hundred things long. So just because you have that and you have sarcoidosis does not mean that it's related to the sarcoidosis, definitely. A lot of what I do and a lot of what we do with the diagnosis here is pattern recognition. And there's certain patterns of bleeding and patterns of changes in the eye that are more consistent with sarcoidosis. But just like Dr. Harper was saying, we can never be 100% certain. We can base it on a preponderance of evidence. And because we rarely do a biopsy in the eye to get a confirmatory diagnosis, we can never be 100% certain, but usually we can get to that 97, 99% certainty that he mentioned. I would agree with that.
And I'll just go through two others. I'll mention them right off the top. Can it cause migraines? Can it cause double vision?
Double vision, absolutely. Migraines, less likely. That would be a little unusual.
Okay, great. And so, Dr. Harper, back over to you. We had a number of people that were questioning around the side effects or potential organ damage that can result from taking some of the different therapies. What do people need to know about monitoring those side effects and potential organ damage?
I think the big thing for azathioprine and methotrexate and mycophenolate is that the reason we do all the blood test monitoring is because in the vast majority of cases, if there is any abnormality, it will go back to normal after we stop the drug. And I think that's an important point, both to make it so the drugs aren't aren't as scary as their bottles sound, and also to highlight the importance of making sure that when you're on a drug like this, you are getting the labs that are recommended by your treating physician. Infection is also a big one. And the key there is really letting your doctor know if you're having symptoms early, so that we can maybe stop the drug for a couple weeks, maybe do antibiotics a little sooner so that we don't get into trouble.
Thank you so much. Dr. Sharma, are there any particular symptoms of sarcoidosis in the eye that is very dangerous or a big concern for you?
Yeah, so as I mentioned, severe vision loss is often very concerning, and that can happen suddenly or it can be slow onset and continuous until it leads to severe vision loss. Now, those are the most concerning ones because with severe vision loss, we often need to be very aggressive with therapy to try to return some of the vision. And even when you are aggressive with therapy, it can be very difficult to get the vision back. So blurred vision that's worsening over time is concerning, where sudden onset of blurred vision is probably the most concerning symptom.
Thank you. Dr. Harper, we got a couple of questions around when you started off with the bones and concerns about bone fractures, bone breakage, and also around nerves and the nerve impact that can happen from sarcoidosis. Could you say a little bit about each? Oops, you're on mute.
Oh, you're muted.
Uh, Zoom. You would have thought I would have learned at this point. So we were talking about bones,
Bone
bone
and
fracture.
nerve pain that can
Yeah,
result from
nerves. Okay.
sarcoidosis. Yes.
So those are kind of two different things. Nerve pain is something I am always I'm very alert for because neurosarcoidosis can be sneaky. And that's something I always ask patients. Are you having nerve pain? Is it always there? Usually the nerve pain of sarcoidosis isn't coming or going. And I have a very low threshold to talk with my neurology colleagues and say, hey, is this consistent with neurosarcoidosis? Is this consistent with something else? What sort of testing should we do? Um, with fractures from sarcoidosis, I have seen a lot of fractures from steroids. I have not seen a lot of fractures from sarcoidosis of the bone. So that's kind of my message there. I will say sarcoidosis is different in everyone. And if someone had a fracture and there was a big old like granuloma at the site of the fracture, could it be due to the sarcoidosis? Potentially. But that isn't something we worry about frequently. Our main concern is has the has the patient have we as doctors given the patient osteoporosis with all of the steroids?
Thank you. And um, kind of building off of this, there's a question around vitamin D and sarcoidosis and a lot of concerns around vitamin D. Would you mind saying a little bit about when it's appropriate to take vitamin D for someone who has sarcoidosis?
The jury is still out on vitamin D. We're definitely concerned about sarcoidosis patients taking vitamin D because the granulomas of sarcoidosis convert vitamin D to the active form of vitamin D that can cause high calcium in the blood, which can damage the kidneys. What is less clear is what we should do for patients who, say, live in Ohio and it's winter and their vitamin D is very low and their calcium is very normal and they're having fatigue. And and in my practice, I have started for some patients giving them a low dose vitamin D supplement, but it's very important that if you're doing that, your doctor knows and they're watching your calcium levels and that you're not taking very high doses of it. I believe there's a trial of vitamin D in sarcoidosis on on clinicaltrials.gov, but it hasn't been reported. I'm not even sure if it started enrolling. I will look into that.
Thank you so much. Dr. Sharma, we had one of our attendees note that they were told by their ophthalmologist that the best path is to follow up with an optometrist annually. What is your advice with regard to someone who's living with sarcoidosis?
So I think initially the initial exam should be with an ophthalmologist, but after your first year or two, if there's been no signs of eye involvement, it's okay to have one of your optometrists do that screening afterwards. I think my concern about the initial exam is always if there's subtle, very fine signs of inflammation, we don't want those missed. But if you get past the first couple of years after your sarcoidosis diagnosis, we have not seen a high incidence of those subtle findings. It tends to be more acute and symptomatic after that. So often after the first couple of years of exams with me, we will switch over to one of our optometrists for the follow-up. Now, with one caveat, we actually have a new program that we have been demoing and trialing here at Cleveland Clinic, where we have an optometrist who specializes in sarcoidosis, and he has been doing a lot of the initial screening exams. But we're doing it as an imaging heavy setup where the patient actually comes in and gets photos of their retina, gets a scan of their retina, and we use a combination approach of using actually an AI algorithm that looks at the images plus the exam from the optometrist. So we have been trialing this, and we're going to be putting some of that data out there soon to show how it compares to an exam with a uveitis specialist, and can we try to get the screening wider is the goal. Is because not everyone has access to a uveitis specialist, and if we could develop a program that helped do that screening for you and would increase the pickup rate of cases of inflammation, then that would be fantastic. So we've been trialing that out. If you're here at Cleveland Clinic and you've been told that, that may be why.
What are the symptoms for an acute attack that people should be aware of if they do move over to the optometrist, for example?
Yeah, I think the big ones to look for are a combination of pain, redness, and light sensitivity, or blurred vision, or new floaters. Those are kind of your five big symptoms: pain, redness, light sensitivity, floaters, blurred vision. If you have any of those, that's a reason to get in with an ophthalmologist for an evaluation.
Fantastic. Thank you. Dr. Harper, we have gotten a lot of questions around fatigue. So there's questions around fatigue and exercise, but also around guidance with regard to medications and whether the medications themselves are causing fatigue, or what medications do you lean on the most to help limit fatigue?
Mhm. I think fatigue is the most important symptom in sarcoidosis right now, and it's the one that we have the least answers for. Um, I'll start off by saying 70% of patients with sarcoidosis have severe fatigue. And we say that the fatigue is multifactorial. When I see a patient with sarcoidosis with fatigue, the first thing I do is rule out all of the easy causes of fatigue. I make sure there's no sleep apnea. I make sure the thyroid's working. I make sure there isn't any anemia. Unfortunately, after I do that, I'd say I find a cause of fatigue in maybe one of every 50 sarcoidosis patients. That's easy. After that, I do start looking at the drugs. And this is really thinking about timing. Methotrexate is a once a week drug, and I have some patients who tell me, "Listen, I am completely wiped out for 3 days after my methotrexate dose, and then I feel fine." And those are patients who I'll say, "Okay, let's think about switching drugs." I've had interesting experiences with the TNF inhibitors, infliximab and adalimumab. Most patients I see, I feel that the drugs really, if anything, help the fatigue a little bit. But I've definitely had a couple patients who have this weird paradoxical reaction. I have one patient in particular who was telling me for a year that after her dose of Humira, she felt bad for 4 days, then she felt good for two, and then she had to take the Humira again. And she did feel better when we stopped it. Unfortunately, though, I think for probably 50 to 60% of my sarcoidosis patients with fatigue, it really seems that the fatigue is coming from the sarcoidosis itself. And we know that that fatigue usually doesn't respond to all of our immunosuppressant drugs like prednisone and methotrexate and the TNF drugs. And I think of it a lot like a lot like the symptoms we saw in post COVID, where people have COVID, they have this big inflammatory state, and after it's over, they have a couple years of just feeling bad. Um, Fortunately, I would say a lot of patients I see with sarcoidosis fatigue, it seems to correspond with like some sort of increased activity in sarcoidosis. and it seems to get better over the period of a year or two. We do sometimes try stimulant drugs. I typically use modafinil because it is a drug that is used for narcolepsy. There's a lower concern of people developing a tolerance to it. And there's a great good RX coupon for it, which makes it so it's actually affordable. Um, but for many patients, that doesn't particularly help either. I will say we're doing a lot of work at Cleveland Clinic. I'm working on getting a trial together of mindfulness-based cognitive therapy. And this was actually driven by the Sarcoidosis Community Advisory Board, who really pushed me to look into alternative therapies. And there actually is some good data out of the Netherlands that mindfulness-based cognitive therapy can improve fatigue in sarcoidosis patients. It's a very structured program. It's challenging to access currently, but we're hoping that we can show that it works and hopefully over the next couple years, improve access for sarcoidosis patients for that treatment modality.
Thank you so much. Dr. Sharma, when you are treating ocular sarcoidosis, are you also concerned about neurosarcoidosis?
Yeah, that's often a concern, and there's often a big overlap. And that's one of the reasons why when someone comes in with eye disease only, we push for a diagnosis quite often, and often we'll proceed with a bronchoscopy with the lung biopsy for the diagnosis, because I've had many instances years later where we see lesions in the brain and it's initially thought to be multiple sclerosis, but having that biopsy of the lungs with a diagnosis of sarcoidosis gives us a little bit more confidence that it's probably not MS and is actually sarcoidosis. So yes, there's often a concern about neurosarcoidosis, but most patients with ocular sarcoidosis do not develop neurosarcoidosis. It's a minority.
Thank you. I'll continue with you for a moment. We've had we have someone who had indicated that they have had optic nerve and disc inflammation, and they've been advised that there aren't treatments to adjust that. Do you have any other thoughts on like whether there are treatments to help adjust for optic nerve
So
inflammation?
there's definitely treatment for active optic nerve inflammation. However, the damage that's been done often is irreversible. So once you treat the acute phase, any residual deficit from that optic nerve inflammation cannot be recovered.
Thank you. Dr. Harper, we had a number of people that were interested in what test you would use to determine what treatment is best for someone. Are there genetic tests that work? Is CT a good way of assessing it? Do you use pulmonary function tests? What are you using to determine what is the best treatment for someone?
There's kind of two questions I ask myself when I'm picking a treatment for a patient. The first question, which is often hardest, is do we actually need to treat the sarcoidosis right now? I think I saw one question that gave the example of a very small progression on the CT, but there aren't any symptoms and the PFTs are stable. And that's a person who I really would have a conversation with. And if they're feeling very good and they have a lot of a, a lot of reserve and they had symptoms from treatment in the past, I probably wouldn't treat them. But if they were someone who didn't have a lot of reserve and tolerated treatment really well in the past, then I might treat them. So it's really putting everything together. I typically want imaging or testing showing that there's some sort of worsening of function of an organ, and then I want symptoms that show that this really is progressing. The difference there is for things like neuro or cardiac sarcoidosis, where we often will treat based just on changes of imaging because any loss of function isn't gonna be recoverable and is so detrimental to quality of life.
Dr. Harper, I'm very sensitive to time for both of you, and thank you for staying just a little bit beyond, so we can continue with the questions. But Dr. Harper, one of the questions was around emerging therapies that are being utilized for more advanced sarcoidosis. So IVIG or JAK inhibitors. Could you say a little bit more about those?
Yeah, I am really excited about the future of sarcoidosis right now. I feel like there's been kind of a revolution of how we look at sarcoidosis. I showed you some of the early trials of drugs, and by current standards, they are rather rudimentary. There have been recent studies of JAK inhibitors like Xeljanz, where they were done very well. They were able to show some of the molecular pathways, and it's much more convincing than the evidence we had in the past. So I'm very optimistic about the JAK inhibitors. I will say I have not been able to use a JAK inhibitor yet because insurance has denied me at every go. So we're still having some access issues. Other drugs that are coming online, there's really great biochemical and trial data of sirolimus, which is an older drug. That drug I have actually had some pretty great experience with, and that's been easier to access because of the reduced cost. And then I have to say, there's several trials going on. There's a JAK inhibitor that is enrolling now for a phase 2 trial. I believe they finished enrollment for efzofitimod, and we're waiting for the trial results, which I believe we're going to hear in the fall. So I think we're probably, I hope, a year or two away from having a drug fully FDA approved for sarcoidosis, which we haven't had before. And I hope I didn't just jinx it now. But our fingers are all crossed.
Absolutely. Well, I want to thank you both for your time and your insights. And I know there's lots of questions that have been coming in, and thank you for answering the questions in the chat. And we, of course, tried our best to answer and ask the questions that folks were putting in. We cannot give direct medical advice, so you may have heard those redirected in a more generic way, but we definitely did our best to try to address those concerns. Dr. Sharma, I will allow you to add in. Dr. Harper just shared what he is hopeful for in the future. What are you hopeful for in sarcoidosis treatment in the future?
Yeah, I think what Dr. Harper mentioned is great. I have used Xeljanz and the other JAK inhibitors in patients with ocular sarcoidosis a number of times, and we've had very good success. The thing that I mentioned in terms of new local therapies in the eye that are not steroids that are coming down the pipeline are what I'm most excited about. The one that's closest to finishing clinical trials is a drug called vamikibart. And it's an anti-IL-6 antibody that's injected in the eye and directly treats the inflammation without the side effects of forming cataracts or high intraocular pressure. The final readout of the study is in this summertime. And then they would file with the FDA. And if it's positive, we would have it available for treatment sometime next year. But then there's 2 other medications that are starting clinical trials that are even more promising for local treatments for sarcoidosis without potential side effects. And so those are what, from the eye standpoint, that I'm most excited about.
Fantastic. Well, Dr. Harper, would you like to close out? I know this is that this is the genesis of your fantastic community group that you've been building there at the Cleveland Clinic for many years. Would you like to say anything else besides inviting everybody to join you in bowling?
No, I think everything's been said. I really want to thank all the patients who came. I am always so inspired by the passion of sarcoidosis patients. And it's really just a privilege to be here. And I really want to thank our community advisory board members who keep me accountable to putting these things on, who help me choose the topics of the talk, and who pushed us to do this bowling event.
Fantastic. Well, thank you both. Happy Sarcoidosis Awareness Month. Katie, I see you came on camera. Would you like to add in? Let me put you up so everyone can see you. Okay, go ahead. Would you like to add something in as well?
I just wanted to thank everybody for coming out. I'm glad I was able to type. I have some laryngitis going on, so I didn't have to speak. But if anyone is interested in joining Cleveland Clinic's community group, we do have a support group that meets on the fourth Wednesday of each month. I did put my email in the chat. Feel free to send me a message and we would be delighted to see you in group.
Fantastic. Well, thank you very much, Katie. Thank you, Dr. Harper, Dr. Sharma, for this incredible session. I think if you've been watching the chat, you've seen lots of thank yous from everyone in the community as well. And we're just at the midpoint, everyone. So let's keep it going for Sarcoidosis Awareness Month. Let's get some more posts out there in purple and keep raising awareness and continue to join us. And thank you to Cleveland Clinic for joining us today on this important discussion. Thank you all. Bye-bye.